Good morning, ladies and gentlemen. Good afternoon, good evening, depending on where you are listening to me from. Let me first of all start by thanking the organizers of this program, the Smile Train and the West African College of Surgeons. I'll be talking about the use of the Vomer flap in palatal surgery. My outline will go this way. Introduction, definition of terminology, indications for the use of Vomer flap, challenges of cleft palate, the goals of treatment, classification and stroke types of Vomer flap, advantages and disadvantages of the Vomer flap.
Excuse me, Prof. Excuse me, Prof. Please, could you put it on slide?
Considerations and surgical procedure. Yes, yes. Yes, sorry.
Could you put it on slideshow, sir?
Sorry. Okay. The reason for the various surgical techniques are just basically because of the failure of one or two to be able to meet all the criteria. So we have the von Legenbach's bipedical flap technique, the Vowadil Kilner pushback technique, Badak's 2 flap procedure, Fulo double Z plasty, intravelar veloplasty, the Vomer flap, which is what I will be talking about today. Again, if you look at the reason why we are talking about all these various surgical types, all of them is just because there is an attempt to actually increase the length of the nasal mucosa so as to prevent velopharyngeal insufficiency or velopharyngeal dysfunction as a whole. And to achieve this, several procedures have been done by the use of the split skin graft up to the use of Vomer flap that was the first used in 1926 by Pichler. The first Vomer flap that was used by this author was actually an inferiorly based flap, and the whole controversy about effect on the mid-facial growth is actually based on this basing of the due to the inferior flap to the Vomer flap being based on inferiorly rather than superiorly. As time went by, a lot of the authors changed the system and then started using it, suspending the flap superiorly. The definition, a Vomer flap is a type of palatoplasty surgery that uses the mucoperiosteal tissue of the vomer to cover a unilateral or bilateral cleft palate. That's the simplest definition. And then the uses of the Vomer flap, it could be used as nasal lining. And this is what is usually used for most often, or as an oral lining. And the oral lining is just the posterior part where you are supposed to have a defect here following the use of it nasally. That's where you turn it up to come and line the oral cavity. And this was actually used by Agrawal and Panda in 2006. It could be a 1-stage or 2-stage procedure in the treatment of palatal surgery. It could either be 1-stage or 2-stage procedures. And usually, if you are using it at 1 stage, you will use the Vomer flap at the same time with the palatine flap to close all the defects.
Is Prof getting me? This is Dr. Oben for Prof. Is Prof getting me? Hello, Prof.
Hello?
Can you remove your video? Can you stop your video?
Yes,
Hello, Prof.
I can hear you.
Yes, can you stop your video? Can you stop your video?
I can hear you.
Yes, stop your video and just share the slide with us so that we can hear you better, so that there is no interference. Just stop your video and share only your slide, and then we will follow your audio and your slide. Thank you, Prof. Thank you so much.
Thank you very much. I've stopped the video.
Good. Very clear now.
Am I okay now?
Yes, you're very clear.
Thank you very much,
Prof. Go ahead, sir.
Okay. So the two-stage procedure involves using the Vomer flap, and at the same time repairing the lip and leaving the palatal part. While as a one stage, you repair all the old length of the cleft together. And this was used by the two stage was Kendrick and those. The challenges of the cleft palate, I'm sure a lot of previous lectures have spoken about this, but I'll just go through it. The speech defect, which is a misarticulation, hyper-stroke nasality, and then nasal escape, feeding difficulty, infection, air challenges, and of course, the dental challenges. And then what are the principles of surgery? The principles of surgery in the use of, involving the use of the Vomer flap is basically the same as just in any treatment of any of the surgical treatments you've chosen to use. The closure of the defect and the correction of the abnormal position of the muscles of the soft palate, especially the levator palatini. You realize that the cause of the main problem is actually this muscle insertion of the during cleft. And all what we should aim at is to reconstruct these muscles and actually push it back posteriorly so as to be behind the palatine foramen, behind the palatine bone, which is usually missing in the cleft palate. So is the reconstruction of the muscle sling actually, and then repositioning of the soft palate. As you move the muscles of the soft palate posteriorly, you will be reconstructing, you'll be repositioning the soft palate so that this during speech and posterior part of the soft palate can come in contact with each other. And then we should have minimal side of the or the oral surfaces. If you have raw areas on all those on the nasal or the oral side, you are likely to have a breakdown of the structures. Then while suturing, the suturing should be tension-free, particularly the palatine, the oral mucosa part. This area, these flaps, these two finger flaps should actually be tension-free so as to allow free growth and reduce mid-facial retardation. Then the two-layer closure should be in the hard palate region and a three-layered closure in the soft palate region. The goals of the surgery. The goals of the surgery basically are to create the creation of an air and watertight velopharyngeal valve, the preservation of hearing. So, because if the patient develops otitis media, there could be difficulty in hearing at a later stage. And while preservation of the facial growth is necessary, so that at least the mid-facial growth can be encouraged. Then there is the creation of the acceptance of functional occlusion, which the creation of the acceptor functional occlusion, which has to be achieved if it is corrected. The creation of acceptable aesthetic dentition. In this what we have here now, we have, you can see where the tensor palatini muscle is there, and the levator palatine muscle compared to in the normal palate, which is just posterior to the palatine foramen and at the back end of the palatine bone. This is the ideal, but in the cleft palate, this is what we have. So all what we aim at is these two muscles. The palatine muscle, move them slightly posteriorly, suture them together so that it will be behind this and behind the palatine bone is supposed to be. Then there are various classifications of various ways of
Hello, everyone. It seems like we lost the speaker. Please bear with us. We are trying to connect with him. Thank you.
Hello? Dr. Oben.
Yes, Prof, we are getting you. Just go ahead, Prof.
I should share my slide again?
Yes, share your slide. Share your slide,
Okay.
and then you continue. Thank you. Thank you so much, Prof.
You've seen it? Is it okay?
No, we are not getting your slide. Bonjour encore une fois de plus à tout le monde, surtout les gens qui parlent en français. Nous, on a des petits problèmes avec la connexion du professeur Ajike. Juste patienter pour quelques temps. Oui, merci. Okay, thank you, Prof. Go ahead. Hello, Prof. Are you still there?
Yeah, I want to turn it to slideshow.
Yes, okay, then go to slideshow.
Thank you very much.
Yes, remember, Prof, to put off your video.
Network.
Okay.
Yes, I'm here.
Okay, just remember to put off your video and keep the slideshow going.
Okay. Okay.
Yes, Prof. Wonderful. We are getting.
Are you seeing my slides?
Yes, I'm seeing your slide. We are seeing your slide.
Okay,
go ahead.
Thank you very much.
Okay, Prof.
Okay. So this is based on what we see here. What we see based on what we've seen in our center. This is a unilateral cleft palate, and that is the vomer bone. Sorry. That's the vomer bone, and that's the vomer flap. And you remember that it is the laterality of this vomer flap that will determine whether it is a unilateral or meets either of the palatine shelves. You will have a unilateral cleft palate. But where it stands, it comes down and does not meet either of the palatine shelves, whether right or left, then you will have a bilateral cleft palate. So this is a left unilateral, because this vomer bone is actually meeting, or there is a union here with the palatine shelf on this side, while on this side on my right here now, there is a union on the left palatine shelf. So this is a right unilateral cleft palate, while this is a left one. And then the ones in the middle are basically the bilateral cleft palates. The advantages. What are the advantages of this Vomer flap? The advantages are, one, that it is very simple and easy to execute. The quality of tissue is similar to that of the nasal mucosa. It was Millard who said some time ago that the best tissue for any area for replacement is actually the tissue nearest to it. So the nearer the tissue is to that area, the better, or the better the tissue. So you realize that for this palatine flap, for palatine repair, the vomer flap is actually part of the nasal mucosa. So, and it's in the best proximity, and it matches in color, and with good vascular supply, it can easily be modified and can be used to close clefts in the vo cleft type 3, which are basically the wide clefts. The disadvantages. What are the disadvantages? They are just basically two. Is that when the vomer bone, the vomer flap can only be used if it is of an adequate size. And the other one is when it is readily visible in the oral cavity. If it's not in the oral cavity, then it's not there. Then you cannot use it. So those are just the disadvantages. Then what do we do pre-surgically? Pre-surgically, just like previous authors must have gone through, lecturers must have gone through this. I will just go through again. The timing of surgery still remains contentious. No general consensus has been given, but in those days it used to be 18 months to 24 months of age. Now it is, some people would say 12 months to 18 months, while some would say 3 months to 9 months. Like I said, it depends on if it is going to be one stage or two stage. If it's going to be one stage, those who repair the cleft lip at about four months would have repaired the vomer part at about that time too. Those gap would have reduced. We'll be able to close the soft better. Then want the cleft to be repaired as soon as possible, as early as possible, because of speech development. So they will be bothered. While the orthodontists will be so bothered about malocclusion, the midfacial growth, retardation, and all those things. They've actually realized that even if the cleft is not done, the palates are not done, even up overgrowth, And then at a later date, when you want occlusion, malocclusion, to be able to get acceptable occlusion, you might have to be doing osteotomy, various osteotomy procedures to actually get correct occlusion. Then what does the SMILE train say about the timing? Generally, they will say that the patient should be at least 9 months of age. So we do our own cases at about 9 months, just before the patients themselves start babbling and start making, attempting to make sounds. So that's it about the timing. Then other pre-surgical considerations will include the type of cleft, like I said, whether it is complete or incomplete, bilateral or unilateral. Then the nutritional status of the patient. Is the patient ready nutritionally? You know, they always have a problem with feeding, and I'm sure we've been able to have a series of lectures on nutrition. The health status of the patient. Is the patient healthy at the time you want to do the surgery? Is there cough, cold, pneumonia? If any of these ones are present, definitely one is advised not to do it. A patient with cough, cold, pneumonia, intubation, you push down all those infections into the lungs directly. So it is advisable not to do it at that time. The age of the patient, well, I've spoken a lot about that. And then growth and development, the patient must have been having normal growth and development generally. And then routine investigations, generally the full blood count, E&U, and creatinine, or at least all those ones should actually be within the normal range. Then are there other anomalies? Is this patient syndromic or non-syndromic? We've had cases where we've had with hydrocephalus and meningocele, and then the neurosurgeon said, go ahead with whatever cleft you want to do, and then we'll attend to it the other time. So this has to be. So when you have other anomalies associated with it, it's better to have it in conjunction with of the routine investigations will be I just got part of the various ways specialty feeding devices. A patient, and it came with this lip, bilateral cleft lip, and bilateral cleft palate. She came in with a nasogastриc tube feeding. That was what was inserted, and that she was told that back to the hospital every week for change it. So that's it. And then feeding bottles are made available to feed them. This is what we use in our own place, courtesy of SMILE train. And another patient came in, this drop for drugs. This is what is used basically for, that was what he was using to drop the milk just by the angle of the mouth for the patient. And then orthodontic plates, of course, to aid feeding. Special feeding bottles, mom feeding bottles, and Dr. Brown's bottle provided by Clapper, Cleft Lift and Palate Association, with bottle with a scoop, or bottle with a scoop, and of course cup and spoons. have actually been used to maintain the nutritional status. Then the surgical consideration include general anesthesia. Surgical procedure will include general anesthesia, positioning of the patient, administration of local anesthesia, incision, raising the vomer flap, the palatal flap, identification of the greater palatine foramen, raising the muscles, and mobilizing the palatal flap medially by turning island flap or chiseling the foramen, the palatine foramen medial. And then there's some authors who actually fracture the lateral pterygoid muscle to release it so as to move it. But this has actually been queried, the turning of the flaps of a repair with the cleft. What we do is we put an incision in the midline, and then we raised. After it has been raised, it is now turned like into an envelope, into a window, which opens and exposes the raw surfaces, while close to the on the oral mucosa or the palatine mucosa. And so at the end of the day, you will have this vomer bone exposed, while this side that is moved turns this way and then turns laterally, and then the flap from the palatine flap turns medially, and they are sutured there. Here, towards this end, occasionally you will have a defect here. And this is corrected by having a turnover triangular flap, which is made to actually suture suture to the palatine side. So it will expose it and turn it the other way around. Rarely do we do that. Rather, what we just do is we just leave it raw there, and then we put in Surgicel, which you will see later. Then positioning of the patient. How do you position the patient? Supine, with neck extended, with a pillow, rolled towel underneath the shoulder, inflated travel pillow. The Indians incidentally have a special pneumatic automatic pillow that they made, and then that actually, so you just put it by the neck so as to extend the neck and then raise the shoulder up. If you don't have any of those things, sandbags at the shoulder region will actually aid you better, so that the patient will be at least will have the head down, and then with the neck extended, and then you'll be able to be more comfortable. While some patients, some surgeons will actually put the patient onto their laps to operate on. Then the stabilization of the head is done by the use of the head ring under the occiput. If you have a pneumatic pillow, the pneumatic pillow or inflatable travel pillow, just like the ones we use on the aircraft when we are traveling, we'll do the neck extension and at the same time stabilize the head for us. Then the anesthetic consideration. This is a great challenge because of absence of the complete alveolar bones, particularly in the anterior region. Oral intubation is usually what is done with endotracheal tube. Reinforced tubes, flexometallic tube is advisable. This is one, a flexometallic tube. And then the curved one is the best. So for intubation, this is the best tube to use. One, because it prevents movement. With a curve, it will prevent the movement of that tube. Occasionally, you could have accidental extubation of that tube. The mouth gag, the gag should be the Dingman mouth gag, because of the groove of the blade, which will not compress the tube. If it is not grooved, you are likely to have compression of the tube, and then you will have cyanosis of the patient and even cut off the oxygen supply. Good suction machine is adequate with good throat packing. And then that's local anesthesia, local anesthetic agent applied. 2% xylocaine, 1 in 200,000 for hemostatics, and then for hydrodissection, sorry, double S there. So hydrodissection, it actually hemostatic effect. So that's it. That's the incision on this side. On the right side, made. And then that's the incision on the left side, made. And that's the flap raised here, and the palatine bone exposed. So we'll suture across. And this is the area I was talking about. So as much as possible, you try and suture so as to close this defect. In case we don't close this defect, what we just do is we just put Surgicel here. And that's almost at the junction of where that palate is, where the vomer palate palatine tissues are starting. And then immediately we will now reoppose the muscles and push them back, suture the nasal mucosa, and then suture the muscles. And that's it. That's the palatine mucosa raised completely. That's the bare bone there, and that's the greater palatine artery. That's this exit there, and then we actually turn this flap into an island flap, sort of, so as to be able to mobilize it medially, and that's it. That's the closure. And after closing, we usually use 3O, Vicryl, for the closure, and then we put in Surgicel to cover any defect. That's it. Pre-op, that's the local anesthetic agent being applied. That's immediate post-op. That's 1 week post-op. You can see the granulation. It has granulated and has covered. And that's 2 weeks post-op. Post-operative management. Immediate post-op management. Positioning of the patient. As we all know, we have to position this patient left lateral position, so that saliva, any blood that is there, can actually flow out. Then adequate suctioning is necessary. Adequate analgesia, we use paracetamol in our center. We give paracetamol, IM, just before the patient, 150 milligrams 8 hourly for the first 24 hours. Then we use we follow it up with syrup, 5 mils 8 hourly for 3 days. And then antibiotics, we give IV during the surgery, just during the surgery at start. And we give 20, and thereafter we give IM 40 milligrams per kilogram, 12 hourly for 48 hours. Minor sedation, we rarely sedate them. We rarely sedate them post-operatively because we want them to get out of anesthesia. And then occasionally we need arm rest and of course IV fluids. So we advise liquids by mouth when fully conscious and no bottle nipples we do not want to create unnecessary negative pressure in the suture line, which can cause disruption. Then after discharge, what do? We tell them no hard foods, no fries, no bread, no crumbs, no fried bean cake, and all those hard tissues, no fried yams and all those things. Why? Because if the patient starts taking all these fried fruits, at the end of the day, it rubs on the tissues and then will cause breakdown. And then we encourage the parents to talk to their children, and then we encourage sucking and then whistling if it's possible, and then the use of mouth organs. This has actually been used in the literatures to actually stimulate VP closure. Oral toileting, this is very important, very important. We actually teach the patients how to do the oral toileting by just using a 5 ml syringe with warm saline water, and then to gently irrigate that area. Because after they've eaten, whether all this, we usually encourage them during their feeding to take this paste, something like all those swallows, semol, and all those things. Those are the local foods we use. We have around us with okra soup, with ewedu. Those are the draw soup, so that at least it will slip down, rather than using vegetable soup. So then suture removal, no, we don't remove the suture after some time. For outcome of surgery, there's ways of assessing the VPI is speech, endoscopy, which is just pharyngoscopy, and then where the feedback is gotten on the presence of nasality in the speech production, and then the video fluoroscopy, which actually measures the swallowing. It detects the swallowing of the patient to see by whether the swallowing reflex is okay. So burial meals are given, and then you scope as it goes. Of course, mid-facial growth is actually assessed by the use of cephalometric. Common one used and cheapest is serial dental cast, where the various teeth are actually assessed, well, for malrotation, for abnormal malocclusion, maleruptions, and all those things. And then the diameter of the cast are measured intermittently. And of course, you measure the outcome of surgery by the complication, which is fistulation, infection, and then wound adhesions.
Hello, Prof.
Complications.
Hello, Prof. This is Dr. Oben. You should be concluding now.
Let's start from where we started from, anesthetic complications. Well, we've seen cases of where there is accidental extubation while the gag was actually being manipulated. Yes. Okay. We are almost there.
Yes.
There. So, yes, I can hear you.
Yes, Prof, I'm saying that Prof should be concluding now. Prof should be concluding right now so that we can go into the questions Q&A. Je suis en train de dire que le Prof doit faire sa conclusion maintenant, comme ça on puisse prendre des questions.
I heard you loud and clear. Okay, okay. Then intraoperative complications, which is bleeding, severance of the greater palatine artery, and then they are all possible ones. Cutting of the endotracheal tube, then cyanosis, which is what I tried to display here. You can see, and this is because this dog, yeah, an origin, and of course,
Hello, we are still having some issues with connection, and we hope that Prof will be able to get to us or can be able to catch up with Prof as soon as possible. For the time being, we have some questions on the Q&A platform. We have some questions on the Q&A platform. We just wait for Prof to get connected again. Hello, Prof, do you get me? Hello, Prof, are you getting me? Hello, this is Dr. Oben, and I'm saying we are having some issues with getting across to Prof. Hello, Victoria?
Yes, I can see he's still online.
Yes.
I think
Can we get to Prof as soon as possible? We have about 9 questions on the Q&A. We have about 9 questions, and if Prof can conclude so that we can be able to take all those questions, it will be very good.
He will. I'm trying to reach out to him.
So please, we are still talking about the Vomer flap. The Vomer flap is retardation, growth retardation, but just as Prof explained, this was as a result of using the posteriorly based pedicle. And if you use an anteriorly based pedicle, the outcome is better. And so please, the Vomer flap is a very important flap. I think we should learn and be able to use it to improve our quality of care, especially speech, because it will lead to a better pushback, for the palate to fall, the levator sling to fall posteriorly, and it will help us to prevent the velopharyngeal insufficiency, which is common with cleft palate repair. Hello, Prof, are you still there? Nous sommes en train de parler du lambeau vomarien, de Vomer. Je sais que c'est quelque chose qui n'est pas bien connu. Nous, on ne connaît pas. Beaucoup de chirurgiens ne savent pas correctement qu'est-ce que veut dire le lambeau de Vomer et la différence entre le lambeau de Vomer et le lambeau de ce qu'on appelle le septal flap. Because a lot of time, we take the septal flap to be a Vomer flap. So please, we are still waiting on Prof. Is Prof there? Hello, Victoria. Do you read me?
Yes, I'm trying to reach out to him.
Very good.
Yeah, I'm trying to call him.
Yeah. So please keep your questions coming on Q&A. Okay, very good. Prof, hello, Prof. Are you there?
Hello, Prof. Have you reconnected?
Hello, Prof. Are you there? Hello, Prof. So as we're talking, we said we must be able to know the difference between a septal flap and a vomerine flap. Sometimes when we do a cleft palate repair, we take a septal flap to do a reconstruction of the nasal floor. And so we want our listeners to be very, to learn, to follow what Prof has said, and to be able to make a difference between a septal flap and a vomerine flap. Hello? Hello, Prof. Are you there?
I'm here.
Okay, Prof. It's quite beautiful. So good for us to know that you're back online. We have. Can you conclude very fast so that you can take 12 questions waiting for you?
Where did I stop? Where did you miss me?
We lost you when you were talking about the complications. The last part of the complications.
Oh, that's far. Let me try and reconnect.
Okay, Prof.
Again.
Reconnect and please put off your video and share with us your screen so that we can follow you quickly and take the Q&A.
Yes, sorry, I'll do that. Oh, wow.
Hello, listeners. Once more, we are talking about the vomerine flap and the importance of this small flap. It's a very small flap, but it's very important as far as VPI management or prevention is concerned. And today, our own Professor Ajike is the one presenting on the vomerine flap. It's a very important flap, and so we can see we already have 13 questions, which means there's a lot people want to know about the vomerine flap. And if we'll be able to perform this flap, it will be a great addition or plus on our quality of care. We want to thank our SMILE train, our God-given SMILE train. SMILE train has completely disenclaved cleft care in Africa, and we want to thank you. And we want to say thank you to WACS for providing this platform on which SMILE train can use to bring further training clinically as far as academics is concerned. Okay, Prof, are you there? Yes, Prof, yes. Can you share your screen? Share your screen with us and put off your video. Thank you.
I've been disabled.
Okay,
Victor, very good. Hello, Prof. Is Prof getting us?
Yes, I'm here.
Okay, thank you so much, Prof.
Well, I've been disabled. I can't share
Prof.
now.
Prof. Now, leave the slide. Leave your slide. Can you? I think your lecture has almost finished. So what we will just do is that I will read the questions for you, and then you can go ahead and answer the questions so that we catch up with time. Is that okay with you, Prof?
Okay. But I would have loved to show one or two slides there. Okay.
Okay, Prof. There is this question from Dr. Tesaye from Ethiopia. What is your experience of using buccal fat? Buccal fat or the vomer flap? What is your experience of the using of buccal fat on the vomer flap?
On the vomer flap?
Yes, Prof.
Using the buccal fat on the vomer flap?
The vomer flap.
I've not actually thought of that. I've not used it, so I wouldn't be able to comment much on that. Hello?
Okay, Prof. The second question is this: for how long post-op is the patient off hard food and fries? I think Prof had answered that question, but Prof, you can go ahead and answer once more. Okay. For how long is a post-op if the patient has to stay off hard foods and fries? From Dr. Anonymous. Okay, it's an anonymous.
Okay, usually we advise that they stay off as long as they can, maybe up to about 3 months. The patient that I showed, maybe you saw the slide, one of them that had the fistulation, the moment they left here, they were not properly counseled. They went back and they started taking, and then it happened after about 1.5 months, and they came back with the fistulation. And once they come back like that, we allow the whole place to be quiet because it could still be lousy with infection and all those things. So we just allow it to be quiet, and then we leave them for about maybe 3-6 months. Thereafter, we now do a secondary repair of the fistulation.
Okay, thank you very much, Prof. Dr. Abdul Kader Bello is asking. He said, thank you for your presentation, Prof. Since no bottle nipples to avoid the negative pressure, can you make opening bigger so that it flows better? He's talking about bottle feeding. Do you want to open the nipple bigger?
Yeah, it's very possible. But again, while doing that, we have to be careful that the patient does not really aspirate. You know, this is a patient that is just learning how to feed now with the bottle. So we have to be careful so that you don't rush in too much of liquid at the same time.
Dr. Asaro Eke is asking, in isolated cleft of the heart palate, will the 2-layer Vomer flap compensate for possible fistula formation if the palate muscles aren't dissected or repaired?
No. Even if you have, once you don't dissect the muscles for repair, then you are likely to have a lot of problems with VPI. So the main essence of the muscle dissection is not because you do not want, it's basically because of the VPI that you want to correct and to lengthen the velar part of the palate. So it is mandatory for good results at the end of the day to do a muscle dissection.
Dr. Abdel Karil again is asking, he said, thank you for your presentation, Prof. For the oral toileting, can you assist with syringe and active suctioning or patient gargles? What do you prefer?
Well, yes, we advocate, these are babies of 9 months. For them to be able to gargle might be with a lot of difficulties. They would rather just put the fluid in the mouth and will almost swallow it at the same time. So we tell them if they can gargle, good. But usually we use the syringe just to syringe the oral cavity by the mothers. That's what we advise.
Okay, Prof. Thank you very much, Prof. Dr. M.L. Jich Ose is asking, dans quel cas devons-nous éviter de faire le lambeau vomerin? On which cases, what are your indications for not doing the vomerin flap? Where we do not do the vomerin flap?
Simple. Where the vomerin flap is not in the oral cavity.
It's not indicated, yes.
If it's not there, I can't use it. If it's there, then it's very useful.
Okay. Dr. Osaro Eke is asking, sir, I would like to know if there is a comparable advantage of the Vomer flap technique in correcting velopharyngeal insufficiency in cleft of the soft palate.
You cannot use in cleft of the soft palate. The vomerin flap can only be used, one, if the vomerin flap is involved, and for the is in the oral cavity. And for the vomerin flap to be in the oral cavity, it simply means that this patient has a complete cleft of the palate. So if you have soft palate, vomerin is not available for you to use. So it's not there. So don't forget that the soft palate will almost start at the junction of the hard and the soft palate posteriorly. So the vomerin is not available for you to use.
Wonderful answer, Prof. Dr. Sunday Chukwara is asking, sir, what are the advantages of the two-stage procedure?
I've not practiced two-stage procedures. Those who practice two-stage procedures have shown this to be the main advantage. One, where you have wide clefts. Some authors believe that if you close the anterior part, you are likely to narrow the posterior part. It becomes less, the growth in width is reduced, and then the growth in they've measured the gap between the alveolar bones anteriorly and measure the posterior cleft, and they realized that doing a two-stage procedure, the palatal side will actually reduce after doing the first stage, so that when they come back to come and do the second stage, they realize that there was narrowing of the cleft, which is an advantage. That means you have more tissue and less space to close. Thank you. Did you hear me?
Yes, I got you. We got you very clearly, Prof. Yes, we do. I got you very clearly, Prof. Now, there is Dr. Rose Faye who is asking, je voudrais tout d'abord remercier le Prof pour sa présentation et demander si, après l'intervention, il mettait un sonde nasogastrique pour l'alimentation. I just want to thank Prof for his presentation, and I want to simply ask, after his operation, do you use a nasogastric tube for feeding? Hello, Prof. Are you getting me, Prof?
Okay. Beginning, we used to. Yes, I got you. Are you there?
Yes, I'm getting you. Yes, Prof.
Okay. In those days, we used to use it, but now we realize that it is better the patients feed orally. And by feeding orally, they are more inclined to cleaning their mouth. So now we don't use the NG tube again. So we just allow the patients to feed soft diets for almost about 2 to 3 months, and then with good oral toileting. So we've stopped using NG tube.
Wonderful, Prof. Joseph Amuda is asking, in encouraging velopharyngeal growth or development, you advise patients to whistle or use mouth organ. How do you achieve this in a patient of such an age, such as 9 to 12 months? Hello, Prof. Is Prof getting me?
Yeah, very, very interesting. I expected that.
Yes.
I have not used it. Yeah, I was expecting that question because I wonder too how you tell a patient of 9 months old to whistle. You know, I have not used it, but I've seen it in the literature. So, and I just felt, well, if somebody probably has used it before he could have recorded it. I have not used it, so I don't have experience with it, but it's there in the literature.
Okay. Dr. Simeyu Adetunje is asking, sir, thank you for the beautiful presentation. In case of injury to the palatine artery, are you not sure of, and you are not sure of one of the Vomer flaps? What should be done, sir? In case of injury to the palatine artery, and you are not sure of one of the Vomer flaps, what should be done, sir?
Thank you very much. Usually, some of these things in the principles of plastic surgery and elevation of flaps, once you cut the vessel, it is advisable just put it back and suture it over and leave there, because you've already compromised the vessel, so it's going to be necrotic. So if you do that, then you resort to spiritual exercises. You start praying that, no, on a very serious note, you hope that it will take itself back. That's just the only thing. And then if you do that, then you might have to cover the nasal lining and what you have produced, then you may have to take something like skin grafting. Skin and graft the whole area with skin. That's just what you do. And one important thing, what I normally do is when I'm suturing the palatine flap all together, what I do is that I suture the palatine flaps alone. Then I now put occasionally 2-3 sutures all through the flap, the palatine flap, the muzzle, and the nasal flaps. So I put the 3 together so as to reduce any dead space in between those 2 layers. And of course, if there is any space there, I put in Surgicel in between the area. The most important thing is that I do not want to leave any raw area exposed. That's just all. So
okay, Prof. I just have some few questions to ask still. I will combine them. Intraoperatively, in the absence of Surgicel, will the outcome be poor? And if the Vomer flap has to be modified, what technique can be resorted to? That is from Dr. Osaro Eke. Dr. Simiyu Adetunde is asking, so how long will the Vomer flap surgery last from your experience? And the last question is, I understood it is used to narrow a previously wide cleft. Thank you, Prof. I think that's a comment. So, Prof, can you take those 2 questions or 3 questions first?
Sorry, the duration is about, it will take about 45 to 1 hour to do on the average.
Yes.
Hello?
Yes, Prof, I'm getting you about 45 minutes to 1 hour on the average.
45 minutes to 1 hour on the average. That's from the start of your knife to the dropping of your needle holder on the average.
Now, in the absence of Surgicel, will the outcome be poor if the Vomer flap has to be modified? What technique can you resort to? Good.
In the absence of the Vomer flap, in the absence of the Surgicel,
yes.
Ideally, you are not supposed to leave any raw area. So what you do is that you make sure that you close the lateral margins as much as possible. And in closing, what I before I started using this Surgicel, it was an idea I got from Changun during one of the cleft palate sessions about 10 years ago, and I've been using it since then. It's very good. And if you close it and then you try as much as possible to put a piece of gauze between the tongue and the palate, and then it actually molds it into the area for you, and then chalk the edges together. The main aim is that you must reduce raw area. Thank you very much.
Thank you so much, Prof. It's been a very wonderful presentation, and the questions have been very active and very, very participative. I just want to make a comment on one of the questions that was previously asked on the buccal fat part. In the area, or when you have a raw surface on the sides, you can actually mobilize the buccal fat part, and you bring it as Surgicel and cover the raw surfaces, as Prof was saying. That is, I don't know if the participant is still there. You asked a question about the buccal fat. Yes, you can mobilize that buccal fat and pull it anteriorly and close the lateral raw surfaces with it. It's been a very wonderful presentation, and I want to thank all participants. I want to say thank you to SmileTrain. I want to thank the WACS for providing us this platform. Now I hand over the microphone to SmileTrain. But remember, tomorrow is another rendezvous. Don't miss it.